There we go. Okay, so I'm actually gonna start. I'll start with leadership first because it's probably a shorter thing. And this one's not gonna be an outline for you guys to fill. It's just kind of like a very tiny little thing, just getting the basically the most important stuff out of your lecture that you guys had. So I would say the most important things are pretty much everything that's listed here. It's going to be a lot of delegation, prioritization, and when it comes to the actual application of it on the test, you guys should expect questions about like your team has, you're the nurse, you have a CNA, an LVN, or you maybe you don't have, maybe it just says you have an LVN, or maybe you just have a CNA. And it's like, which task can you delegate? Can you delegate this? Or you'll have one where it's like you have four patients, which one is priority, etc. So those are the type of questions you guys should try to look and practice for. That's more or less how the questions will be asked. But you should also expect having to know the five rights of delegation, for example. And then the key points about delegation is even though the RN, if you delegate a task to your CNA or LVN, um, the responsibility of that task is now on that person, but you're still the one held accountable because you had them do that task, and you were the one that provided instructions for it. So even though you're no longer in that moment responsible for doing the task, you're still accountable for it. So that means it's your job to follow up and see what was done of it and what kind of came up of it. And then it's important to know the five rights of delegation. So was it the right person? Was it the right task for the um right person? So a CNA or LVN. Was it the right circumstance? Was it appropriate for you to have delegated that task? So what does that mean? You can have tasks that you normally can delegate to like a CNA, but in certain circumstances, it might not be appropriate to have them like do vital signs because maybe it's a really unstable patient and sending them out to do vital signs and then going somewhere else, the CNA is technically not able to quote unquote interpret what the vital signs are and make actions from that point on. So in a case where the patient is unstable, um, for example, it would be probably up to you to do it. Or another one is a patient with a stroke who has difficulty swallowing. And it's going to happen in real life, but the idea would be that you would try not to delegate that to the CNA, because if something happens, they technically don't have the ability to assess per their role. So in that scenario, it would be better if you were to do it per per the book. Again, right communication. So that essentially is referring to what is the proper way to give instructions. So you don't just like in like a situation, you might be like, take the vital signs for this patient and keep note of the patient has a history of mastectomy, so they can't get their blood pressure on their left side, for example. Or you'll tell them for if their blood pressure is above a certain amount or below a certain amount, make sure to immediately call me and we'll act on it. So giving the communication and like parameters or just like more clear instructions so that they know what to do. And there's a little bit more nuance can make it more safe for you to delegate because then they kind of know if this happens, then they can come back to you and report it. And then the right supervision, which is kind of goes along with the right communication, is that you follow up on it to make sure it was done correctly, etc. It's also good to know the tasks that the LVN or the CNA can or cannot do. So for the sake of the test, the LVNs cannot do stuff with IV, so they can't do IB push or IB piggyback. Um, they also cannot do the initial or a comprehensive assessment, but they can do assessments on a more stable patient. So what does that mean? So if you have a patient with maybe CHF or something, if they've been on that floor for longer than a day, then you can have your CNA, or not your CNA, you can have your LVN assess the lung sounds and then come back to you and tell you what they heard, for example. But they can't do the initial assessment, just kind of like the routine. So for the most part, that's kind of like your key word. They can do a lot of the routine stuff. So routine medications, routine assessment on like a stable patient. As long as it's not the initial or like a very comprehensive one, they're allowed to, do that basic assessment and then report what they heard to you. And then you would do a follow-up after. LVNs cannot perform evaluations, so that kind of goes hand on hand with the other one. So they can listen to, for example, crackles in the lungs, but they're not supposed to kind of interpret it or like make actions based on that. They would have to report back to you, and then you make that decision. So in that scenario where you have like a patient whose lung sounds were clear, like 2 days ago, you delegate your LVN to listen to the lungs and then come back if you hear anything abnormal. They come back, they can hear crackles in the lungs. They come over to you, report that, and then your job as the RN is to come back in there, reassess the lungs to see what the LVN heard, to kind of like get the the reassessment on what the LVN heard, and then go from there. Call the doctor, let them know about the new crackles in the lungs, for example, and kind of go from there. Another thing is the LVNs cannot do initial teaching, but they can reinforce. So maybe you can have the LVN maybe tell them that whenever they're in the room, that tell them whenever they're in the room, they can tell the patient to like remind them that they can do their IS. And then what else here for reinforcement? Maybe they can reinforce SCDs. So you already, as the RN, told the patient that they need SCDs while they're on the bed, or they need assistance getting up. They can't do that initial teaching, but they can reinforce it whenever they're in the room, for example. So these are things that they cannot do. So just keep that in mind because you might get questions like that, where one of the wrong answers is an LVN being able to do one of these things. And then in general, just keep in mind that I would say assessment plus intervention. Or maybe just in general, put it like initial assessment. Yeah, in general, your like initial big comprehensive assessment, your clinical judgment and evaluation cannot be delegated. That's your job as the RN to make the kind of do the interpretation and interventions from there. So just keep that in mind. And of course, your CNA cannot do any assessments in general. Um, and then for the RN, what can you delegate? Of course, here just some list of examples of things you can delegate. You can delegate patient care activities, like I said, feeding or drinking, positioning, all this stuff here. But like I mentioned, and LVNs can do like routine wound dressing changes. But just keep in mind again, how there is that circumstance, the right circumstance. So in those scenarios, like I mentioned, like a patient with a stroke, like they have this phagia or something, or like a very unstable patient, they're not going to have the CNA take the vital signs. You're going to take the vital signs so you can kind of act on it. But you can delegate also collecting, reporting, documenting data. So that includes things like your eyes and nose, um, vital signs, etc. So in general, when you do get prioritization now, so that would be those type of questions where they tell you you have these 4 patients, who do you go to first, or who's more critical? The things for you to always focus on are your ABCs, safety, any change in condition. So keep in mind like keywords like sudden, suddenly, um, things like that, right? That things that kind of show that this is an acute change in condition. Also infection, pain in that order. So ABC, safety, infection, pain, in that order of priority. Or when in doubt, again, just like Kaylin always says, you think about what's going to kill your patient first and act on that. So kind of just how how that goes. So if the patient is bottoming out, their blood pressure is 80 over 50 or something, you're going to prioritize that over the patient with getting routine antibiotics, for example. Like this is they're like on day 2 of antibiotics, you got to replace the IV piggyback, things like that. And that's also how your CP is going to be with, right? It's going to be a focus on your critical ABCs and safety. Other things for you to think about is about stable versus unstable. So think about how a patient with COPD, um, they can be stable, but they can have abnormal vital signs just due to their condition. They can have high respirations because they have emphysema, for example, but that's their normal and whatnot, and you're not gonna prioritize someone with COPD that's having like their against that's why you establish the baseline that's having like their elevated but like normal for them respirations over a different patient with no history of any respiratory condition having the same amount, like the same rate of respirations, if that makes sense. So stable versus unstable, expected versus unexpected. So of course, if it's unexpected, that's more worry for you because it's an acute change in condition, something that's new that wasn't there before. And it kind of goes back to the same thing, acute versus chronic. So chronic patients in pain, that could be chronic, but maybe they have acute pain. Why did that acute pain come from? Like, where did that come from? Why is that happening? Whenever it's something that's again new, it should always kind of bring something to your mind that you should kind of look into it more because it's not expected. And then there's also actual versus potential. So, for example, like in the past, we might have had questions where you have a patient that is at the risk of a airway issue, but they have an actual issue with like their blood pressure, for example. So, to give an example, again, like um, someone with a trach that's on like 2 or 3 liters of oxygen, they have that potential to decompensate, for example. Like maybe they have some other underlying respiratory condition. They have a potential to have an airway issue, breathing issue, but you don't prioritize the potential over an actual, like if they were to have an actual circulatory issue, like their blood pressure, like I mentioned, is like that 80 over 50. Even though your A and B come before your C, the C one is actually happening as opposed to the A and B, which is just potential. You're always focusing on real, actual current issues now, and you're trying to be preventative with the potentials, but you, of course, going to focus on the actual. And then another thing is like systemic versus local. Is it happening on a large scale? Is it happening at a small part? And just kind of another thing to think about. Another one of your key things to keep in mind for the test is this right here. If the patient is a new admit or they've just returned from a procedure, they are considered unstable for about 24 hours. So for that time, because you don't know really anything about them per se, you don't have a baseline yet about how they are as a new admit or right back from a procedure, you want to be doing like Q15 vital signs and um, kind of just assessing them more thoroughly and just prioritizing them because you don't know what could be happening with them. You have no information on them. So that's your priority on that. So also keep that in mind with some questions where maybe the patient's condition, like overall diagnosis, systemic versus local. Sure. Um, I guess an example that I can think about, I guess, uh, maybe like a localized infection versus a systemic infection. So like an infection on like a tiny wound versus like sepsis, for example, or like just a more widespread infection that's causing more systemic issues. So like an infection that leads to like a high fever, like a respiratory infection that's leading to like a high fever, crackles in the lungs, a lot of mucus, maybe some blood in the sputum, versus like a more minor infection, which is just like an infected nail, for example. It's still an infection, but it's not causing like systemic issues, if that makes sense. Just at the top of my head. Um, but yeah, so here I'll give you something that you guys may get thrown at for like a question is maybe you have a priority question or like a delegation question. Let's think about delegation question where it's asking which patient can you delegate to the LVN. They might give you potential answers such as a patient with a diagnosis, like let's say they came in for wound care. Um, for example, like they have like things that are like you could tell from the diagnosis that it's routine, but they also throw in the answer choice that the patient's a new admit. So even though like their diagnosis, for example, is something that you could see an LVN doing routinely, like wound care changes, giving them their daily meds, whatever, because they're a new admit, they are considered unstable and therefore the LVN cannot take them. Does that make sense? So keep note for kind of tricky answer choices like that. And then kind of like I mentioned before, if there's ever any doubt of stability of the patient, like for example, the patient with the dysphagia or the stroke or the guy that's at heavy fall risk, really consider like would I want to delegate this to the CNA or do I should I do it myself or at least get help from another person? So maybe you get the CNA, but you do it together. Um, so that's just things to consider. And then another key thing right here is they want you to really start thinking of confusion or restlessness, especially, acute. Let's go back to acute. Acute restlessness and confusion. They want you to think of hypoxia, which is, let's say hypoxia in this case could be airway, could be breathing, but I think for the questions you guys did, it was typically considered like breathing. So with acute restlessness and confusion, think of it like a hypoxia, in which case it falls under B of your ABCs until proven otherwise. That's something that she really wants you to keep in mind. And then just like your CPE, whenever you are in doubt, you're going to do an assessment. That is your power, that is your tool that you should always think about. Whenever you're in doubt of something, take vital signs, do an assessment. That's how you should approach your CPE as well. If you're in doubt of something, do your assessment. That's how the process is going to go during the CPE and pretty much during clinical, during simulation as well. You guys probably notice that when you're going into sim, something comes up and then you're like, I don't know where to go from here. If you take the vital signs, a lot of the time that kind of gives you a clearer image and you kind of know a little bit more what to do. Sometimes you don't, but sometimes you do. And so whenever you're in doubt, just assess. Any questions on this before? Otherwise, I'll move on to like the application of the prioritization. All right, we're good on that. So this is similar to how you guys did your in class, where you guys went over like a bunch of prioritization questions on this. So your prioritization application, kind of from going those questions, you've probably noticed that for like Brooks's questions, anytime you saw the patient having any complaint, they were considered quote unquote unstable for the sake of solving the question. Um, so that's something to keep in mind for her questions. That's kind of how she wants you to break it down. If they're complaining of anything, they're quote unquote unstable for the sake of the question, for the sake of categorizing everything and then trying to eliminate answer choices. Take into account condition for what can be considered unstable. Take into condition for what can be considered. Yeah. So for example, they have one where the patient has what's that one word called? Myasthenia gravis, right? Myasthenia gravis. I think you guys barely touched on it, or maybe actually you learned that technically this semester. But that's maybe that's not the best example then, because that's myasthenia gravis is more this semester, right? I think so. Yeah, I think it is this semester. But essentially think about what's unstable for each condition. So again, COPD again, having high respirations but stable O2, and patient doesn't look in an acute distress. That's their normal, even though it's considered abnormal, but then knowing what's unstable for certain conditions. So in that person have like being in active distress, using accessory muscles, being tr like tripoding position, there's SATO2 decreasing despite treatment. Those that would be considered unstable. Or even thinking of if you guys go back to like your pediatrics, um, we learned about very minor, but we learned about like tonsillectomy, I think for like a little bit. If the patient is swallowing a lot, it sounds like something like a random little thing if you don't think about it too much. But one of the major complications of the tonsillectomy is that you're bleeding out. And so the swallowing in that scenario is actually them like probably bleeding a lot and then swallowing a lot of blood. So just kind of take into account how the condition affects the question and how it is or isn't stable versus unstable. So like what is stable versus what is unstable for the condition that's put in the answer choice. Kind of like I mentioned before, transferring onto the unit a new admit that's unstable and unexpected. And you should always kind of treat it that way unless there's someone that is, actively, having a like complete 100% definitive issue. Again, back to this, disoriented, acutely, consider it a hypoxia or a breathing issue until proven otherwise. Keep attention into words like sudden. Um, and then, of course, ABCs. And then here's kind of how to break it down for the types of question. Anything in the neck area, consider it airway. Anything in the core area, consider it breathing. Just because, your airway and breathing can be pretty similar. That's just kind of how it is for the breakdown on her questions. And then another thing you can do is split the answer choices. Yeah, the big C and little c. Right. So an example of like a big C would be like bleeding or maybe like severe hypotension, and the little c would be like an edema. So it's kind of like it's difficult to give like a clear to give like clear clarification on it. It's kind of just which one of these is more life-threatening versus this is a circulation issue, but it's not imminent at like peripheral edema. It's a sign of peripheral circulation issues, but it's not like life-threatening when it's peripheral edema, for example. That's kind of what that refers to. So it should be based on topics you're going over. So I know that when you guys had that in class like um thing where you guys went over questions, she probably had a bunch of random stuff you've probably never gone over. That's don't worry about it too much. It's gonna be more about what you've gone over. Granted, it'll probably be what you've gone over throughout nursing school kind of thing, but not too crazy, like not too specific. Like some of the bigger topics like heart attack or respiration, like different types of like asthma or COPD or things like that. It's doable. So it's doable for sure in terms of that. You're not going to get a random question about something you've never heard of. All right. Yeah, last point is that you can split it into like assessment versus intervention. So the idea would be if you have like three answer choices, you have A, B, C, D. You can try to break it down as, oh, this is an assessment. This is also an assessment. This is also an assessment, and then this is an intervention. So from that point on, you kind of make the decision, do I think I need more assessment do I feel like I need more assessment to answer this question, or do I feel like I have enough information? If you feel like you have enough information to continue, then you get to essentially cross all these out and just be left with your one answer that's kind of like this one is not like the other. Or, oops, that's the YouTube links. So this will undo, redo. Or you break it down like this and you determine, actually, I can't act just yet. It's too early to act. I need more information. And therefore you get to eliminate this one and then try breaking things down into, okay, go back to like stable versus unstable. Maybe it's something like this. Or if it's applicable, it might not be applicable on this case. Or you just break it down to ABC. So this is an assessment of your airway. This is an assessment of your breathing. This one's assessment of your circulation. This one's a potential issue, actual issue. That way you can eliminate, and then you know this is your answer instead, if that makes sense. So breaking things down into assessment versus intervention, determining do I have enough information, in which case you can get rid of all the assessment answers and go with and then start breaking down the intervention ones, or vice versa. I don't have enough information. I can eliminate all the intervention answers and then start breaking down which assessment is more important. Make sense? Yeah. And then also keep in mind your nursing school experience will be like this. This is how they're going to do these types of questions from here on out. You're going to get these types of questions probably on every test from here on out. You're going to have maybe like one or two prioritization or delegation questions just throughout. You'll have these type of questions in 240. You'll have them during your Kaplans. And some of your UWorld and Kaplan um, practice questions when you're studying for the NCLEX will also be like this, like pretty similar. But keep in mind that we are functioning still off an older curriculum. So the NCLEX, new NCLEX is actually not exactly quite like this. I think some of the like the UWorld new gen questions on the UWorld are going to be closer to what the NCLEX is actually like. So just keep that in mind that um genuinely the what you're doing now, the types of tests we're doing now in nursing school on this curriculum that we're at right now, that we have, the old curriculum, is going to be harder than your NCLEX. If you can make it through here, you're going to do fine on your NCLEX. Just as long as you're being consistent and you're applying yourself and you're not being, you're not being lazy with it. If you can get through nursing school, you can get through the NCLEX. Yeah, it's going to be a lot easier. Even like your world practice questions, those are going to be harder than the NCLEX or Kaplan practice questions, whichever you decide to do. I recommend you world. I actually didn't even touch the Kaplans, but I liked you world a good amount. But yeah, just keep that in mind. You will have these types of questions throughout the rest of your nursing school. Okay. I'm gonna give you guys this file right now so you guys can save it. Um, Okay, cool. And then whenever you guys feel like you're ready, like if you have any questions, feel free to ask. We'll go through it. Otherwise, we can move on to hematology. Okay, so we'll move on to hematology then. So the main things about hematology is going to be leukemia, lymphoma, and then multiple myeloma. And again, this is going to be um, the most important information. There's going to be a lot of information that we were given that's honestly not going to be something that you have to worry about. I'm trying to just hit the main, most important points. Anything else that's extra, and even you know me, I get a little extra with my stuff too, my random information on here. Um, but we'll try to touch on like the most specific or the most important things that we have here, because a lot of the time you just have to know how to do like a general assessment and then how to intervene, less so than knowing patho. Patho is not really heavily important so much. But if it helps you, then that's where you look it up and where the extra information can help you. But we're just gonna try to get through the nitty-gritty of it. Okay, so for leukemia, I have the main definitions for it. This is a cancer of blood-forming tissues, so that involves your bone marrow. Your bone marrow is where your body makes red blood cells, platelets, white blood cells, as well as the lymphatic system, which includes things like your lymph nodes, and we know we have lymph nodes all over our bodies. And when it comes to like the leukemia, that's kind of where your cancer can metastasize really easily because it's a cancer of essentially cancer of the blood and the lymphatic system. So it has a very wide body, systemic wide pathway for it to spread around and um, and things like that. The main idea in terms of like the pathway that you need to know is that you just need to know that the leukemia is going to lead to the production of immature white blood cells. And these white blood cells are misshapen and not effective. So you can have someone presenting with a very high white blood cell count, but their immunity is still going to be poor because even though they have a ton of white blood cells, those white blood cells are not effective. They're not fit for the job. They're immature, they're not ready to actually work yet. Or they're misshapen and they just can't work, period. But they're being made in mass production because again, the cancer cells can't stop themselves from replicating. They just keep going, trying to build their own blood supply and you know the stuff like the review from 220. And then in terms of leukemia, this will be partial review from 222 that we went over leukemia over there as well because leukemia can be common. You know, the ALL can be a common cancer in children. But then again, breaking things down into the most important parts of each thing. Um, we have the findings. So you have pancytopenia. What does pancytopenia refer to? And what are things you should, if you see something like pancytopenia on your diagnosis, what are the things that you're thinking of? So yeah, here we go. We have low RBCs, platelets, and white blood cells. All blood cells are low. Yes, exactly. So, and then we'll break things down even further. So we'll call what is low platelets called? What's the scientific word for it? Okay, thrombocytopenia. What about low RBCs? Just so you don't get thrown off by terminology. Yes, anemia. What about low white blood cells? Yeah, leukopenia. Although again, kind of keep in mind that with this condition, you can have either low white blood cell count or a high white blood cell count. Depends on how it manifests on the person, the type of leukemia. But the general idea is kind of there that you have low immunity. Okay. So with thrombocytopenia, what are you at risk for? What are some signs and symptoms? Well, I guess that kind of goes here, but sure. What are some signs and symptoms that are going to occur due to having low platelets? What are some things that you might expect or can see? Things for you to look out for? Yes. So bleeding and bruising. Yeah, pretty much going to be the main things. Blood in the stool, sure. And that's called melena, which is blood in the stool, and that's a sign of GI bleed. Oh yeah. Um, yeah, it's kind of like the interesting thing. So even though it's blood in the stool is actually a sign of um, upper GI bleed. It's when you have bright red blood. I guess let me clarify. When you have like occult blood in the stool, like the tarry stools, um, the tarry black stools, that's actually a sign of upper GI bleed, like stomach bleed. It's when you have just acute like bright red blood coming out of the butt without like not like stuck in the stool, like just bright red blood, that's a lower GI bleed. It's just kind of like, you think about like blood coming from down there, so you think it's upper or you think it's lower GI. But a lot of time it's unless you see bright red blood coming from the anus, then it's bright red blood coming straight from there. That's like a lower GI bleed. Occult blood, tarry stools, not red tarry stool, black tarry stools. That's more like a upper GI bleed, like a stomach bleed kind of thing. Anyways, um, yeah, so it kind of goes alongside here, and I'll probably repost them again. With anemia, what are some signs and symptoms you can expect? We kind of talked about it the other day. Sure, pale skin, headache, sure. Fatigue, yeah. Fatigue, potential shortness of breath, potential chest pain, potential. Dizziness is one of the common ones as well. Dizziness. Yes, so all of these, for the most part, probably in this order. These are probably like the most common, and then these are if it's more bad. Oh, tachy, yes, tachy goes here. Probably put that like right here. Because compensation, so possible tachycardia and shortness of breath kind of goes with tachypnea. Yeah, depends on how bad the anemia is. You'll probably see these more common. Okay, perfect. And we kind of mentioned low immunity, so higher risk of infection and difficulty fighting infection. Right, that makes sense because you have less of that. And if we talked about that they're either ineffective or we don't make enough, then that all makes sense there. Temperature, yeah, that can be affected too, for sure. I think so, yeah. Let me close this out. Yeah, so you could have like a bit of a lower temperature. So we'll kind of go with cool, like you can have like cool and clammy potentially. Like as you're going into like shock and stuff, that can happen. So that's a lot of that. Let me see what else I can add on here. Okay. For the most part, that's going to be like a lot of your main things, and then I'll go into a little bit more like specific stuff here. Something that occurs with your leukocytopenia is you have the potential to have Hepatomegaly and splenomegaly. What are those? What do those terms mean? Yes. So if you have an enlarged liver, what are some things that you could expect or you might have? I'm not sure how much knowledge you guys have about this right now, about liver and spleen. I would say those are a bit more advanced cases. I don't think we went over it, so we'll talk about it kind of like this. It's just like enlarged liver. It doesn't necessarily mean it's failing or that it's impaired or anything. But it does come with it can come with increased quote unquote liver function test. So your AST, um, ALP, and so AST, ALP, and the alkaline phosphate. ALP, ALT. Yeah, there we go. AST, ALT, and ALP. And then we can include the bilirubin in there as well. So those are things you might see on like labs. You can see that. Splenomegaly. The main thing you should kind of know about splenomegaly is, yeah, it has a role in managing your red blood cells, white blood cells, and platelets. So it has that ability to kind of take old ones and kind of break them down. When your spleen is enlarged, it does that more often. It has like because it's bigger, it has essentially it has a bigger amount of cells that it can take in and break down. So having a bigger spleen can essentially lead to um, more cell breakdown of RBC, platelet, YWCs. So you have pancytopenia that way as well. So it can worsen your pancytopenia. Um, and then that way you can also, and then this you can also apply to other things. So having an enlarged spleen in other conditions can also potentially lead to pancytopenia if it's very more advanced. Does that make sense? So this breakdown of RBCs, platelets, and white blood cells is the spleen's normal function. When it's enlarged, it has more surface area to take them in and break things down. So it ends up taking more than it should, and that ends up leading to decreased counts of all of it. So with more advanced cases, um, it can lead to worsened pancytopenia. And you can apply that to anything with splenomegaly. Um, so if you see that, you can try to apply that there. It doesn't have to be just leukemia. For the most part, you should just know that leukemia can lead to these two things. As if you want a reason for why it does, um, the reason for why is because your liver and spleen can compensate for the lack of your blood productions. Because your spleen does break down these RBCs, platelets, and white blood cells. Your spleen can also kind of keep some in storage almost to use when it needs it. And your liver can also have the ability to, very minor ability to also try to make some red blood cells or blood cells, all that stuff. So your liver and spleen can become sites of blood production to compensate. Extra info um, that you don't really need to know. Anything that I put in green like this or whatever color this is. Oops. are going to be things that, oh God damn it, going to be things that are like extra info. This is just extra info, just for context. The main important things is going to be kind of knowing this and knowing that you can have these labs with this condition. Okay. So hypermetabolism, uh, maybe for the test, maybe you have to because you do have liver as a concept. So probably, if I recall, when I have, if I recall, for the most part, there's like, most of them are like, you can use like the number 45, and I think most of them, I can't remember at the top of my head. I think most of them should be like under 45 for normal, and then there's one that has to be like above 45 for normal. I'll have to like recheck it because I don't have it memorized either. Yeah, but there was like I created like an easier way to remember it for the liver one. For the most part, at least for your testing, like your NCLEX, they'll give you ranges and stuff for most things, especially like the uncommon things. You'll definitely have like a range for it. So another thing that happens with cancer in general is hypermetabolism. That's why people that have cancer lose weight really quickly because the cancer is building its own blood supply and robbing nutrients from the body. So it is trying to grow itself, which means it's taking nutrients away from the rest of the body, which means that's why there's a lot of weight loss a lot of the time with cancer. So again, that's just like a general cancer thing. Something that they go over in 222 is that the cells can make their way to the meninges in order to kind of get more nutrients, and then that can lead to increased ICP. And I'm just include this. So you kind of have wasting, weight loss, lack of appetite, fatigue, and then increased ICP. So we'll kind of go here. So kind of goes with that hypermetabolism. Your leukemia cells can try to infiltrate the meninges to acquire more nutrients, and signs and symptoms of increased ICP from review from 220. That includes like the headache, the nuchal rigidity, which means kind of like a stiff neck, irritability to um, light and sound, and seizures. And then again, review from 222 about leukemia. This is just essentially a purple rash. Okay. Hopefully I'm not going too fast. Let me know if there's any questions so far. We'll kind of do like a quick go back to the beginning and emphasize all the important stuff again. Just let me know if there's currently like a question that you want to answer right now. I believe it's painless, yes. Let me double check. Yes, it's painless. So if you want, we can take a look at that. So this is probably what it'll look like. Okay, so that's kind of what it looks like. All right, so kind of let's go back up and again highlight the important things here. And I'll kind of just include this important extra information for context. This is your key. Okay, so the main thing here, when you have leukemia, your white blood cells are not effective in fighting infection. So, like I said, this can have high WC or low WC counts. Regardless, immunity is impaired. So that's another key thing. Okay. Going back up to the findings, this is key. You should always remember pancytopenia and then try to break it down into the three things that make up the pancytopenia and some of these signs and symptoms and things for you to think about. So whenever again you see pancytopenia as a diagnosis or like something that's mentioned or you just notice it, these are the things it refers to. You should be looking out for signs of bleeding, signs of bruising, bleeding, and like especially if they're actively bleeding, you know, this patient can bottom out. Um, they might have like what would be a possible like sign of bleeding other than, you know, actively seeing the bleeding, like an internal bleeding, for example. What are some things that might clue you in on someone having like a internal bleeding? Could be a blood and stool. What about things that like for that one you like if you don't see the stool, then you might not know. Weak pulses, that's like a change in your outer level of consciousness, change in pulses. Yes. Yeah, low blood pressure. That's for sure. But again, keep in mind, of course, kind of like when we go over shock, remember your hypovolemic shock includes fluid loss, but it also includes just like hemorrhagic shock. Those are essentially the same principle. So your blood pressure is always being compensated. So changes in BP take longer to become apparent. So, but when they do change, you'll have like that narrowing pulse pressure. So again, that refers to systolic BP that is normal or slightly decreased with diastolic that is increasing. And your number, like your best indicators are, like you guys mentioned, alter level of consciousness, changes in pulse from baseline. Um, I would also say changes in urine output, some of your best ones. If you guys recall, when you're going like hypotensive, your kidneys do the whole RAS system and maintain to whatever fluid you have. Remember, your kidneys compensate as well. You will also have like some not shunt, yeah, shunting. So shunting, so you can have cool skin, cool clammy skin, for example. But yeah, because your kidneys compensate, it also means you're making less urine because your body's trying to hold on to all the liquid it can. So these are some of the best things to assess like an active bleed. Your blood pressure could still be there, but just keep in mind it's not because it's always being compensated on. You might have like a normal blood pressure, quote unquote normal blood pressure, but then have all these other things and some tachycardia, tachypnea as well. So just keep all that stuff in mind. That's your like your main concept when you think about bleeding and when you think about all that stuff. And then of course with anemia, you'll get some of these signs and symptoms as well. And yeah, don't forget, of course, the whole point is that they're higher risk of infection. And we'll talk more about the interventions there. Like I mentioned, the context as for why hepatomegaly and splenomegaly happen, you don't really have to know. Just kind of know it happens. And then when you have it, you'll have a bit more of like the LFTs and splenomegaly in general has the potential to cause pancytopenia or worse pancytopenia. Not immediate, not like always. Depends on how bad it is. Like we mentioned, your cancer's trying to build its own supply, it's robbing nutrients, and that's why you have that weight loss with the cancer patients. With leukemia, especially, you have the potential for it to go to your meninges, which is that layer in your that part of the brain, and then just this layer like above the brain where your cerebral spinal fluid is. It can make its way there and attempt to rob more nutrients, in which case you have very similar signs and symptoms to your meningitis, the headache, nuchal rigidity, etc. So next up, we have like the section on signs and symptoms. For the most part, that's essentially going to be everything we already kind of talked about because we kind of wrote it up above instead of writing it separately. Um, that should be it. So it kind of goes with what we already talked about there. Another thing is you'll probably have some bone pain because remember it's happening in the bone marrow, so bone pain can occur. Anything else? Oh, we can put decreased capillary refill here. Mentioned weight loss. They're immunosuppressed. So all of the pancytopenia stuff. Yeah, that's pretty much it. Any questions on what we talked about so far? Okay. So for your diagnostics, I kind of wrote them out for you, but just tell me a little bit about the bone marrow biopsy. What's it for? What does it tell you? Yes. Yeah, the bone pain related to that. So what's a biopsy for? Yeah, but basically your biopsy is gonna be, let's just say it's the definitive diagnosis. They'll do the biopsy, some other test, imaging, but the main thing, just know biopsy is like your one of your definitive diagnosis. For your CBC, we already kind of mentioned the decreased SNH. Yeah, it's the gold standard. In general, the biopsies will be your gold standard for pretty much all the cancer stuff. But of course, it does come with the other. You still do the other test. Here is kind of like going over like when you do have like the high white blood cell counts on the people with that sort of leukemia. Because again, you can have leukemia that's high white blood cells, leukemia that's low white blood cells. But in the scenario where you have high white blood cells, you'll see that the neutrophils, the active mature neutrophils, though they're going to be low, but the bands are going to be high. The bands are the immature white blood cells. It's called bandemia when you have high presence of bands in the blood. Okay. Position do they do? I don't know. Let's kind of take a look. Leukemia, bone marrow biopsy. It's like they get it from right here. So on their stomach or on their side. That's what I kind of remembered. Take a picture of it. So either on their side or on their stomach. Usually, I guess it's from the like little hip sacrum area. I guess I can include this. Honestly, it's not that dissimilar to the lumbar puncture. I think lumbar puncture, they're sitting down on their back, right? Let me see. Let's see. Well, that's kind of the same thing actually. They're pretty similar position as the lumbar puncture actually. Okay, anyways. What is the lumbar puncture for? You guys remember from 220? Cerebral spinal fluid. So we can remove fluid. We can also assess the fluid. Is there anything that we kind of discussed earlier about leukemia where you might want to like look at the cerebral spinal fluid? Kind of goes with meningitis. Yeah, it can spread. So remember the leukemia can spread to the meninges. So it's kind of there to assess if that is currently happening. And then there's also a, let's do an X-ray. The X-ray is just to assess the bones or assess, the um, area in and then the chromosome analysis is, honestly, I don't think this even came up, but they went over it, so I'll mention it. It's the Philadelphia chromosome, which is your chronic, related to your chronic myelogenous leukemia. I don't think it ever came up. It was just like fun fact. So I wouldn't worry too much about it. I would worry about this one the most. Doesn't mean don't know the others, but it does mean focus more on these. This one, I'm just gonna give a soft highlight, soft underline. Okay. Does it make sense that these are the tests that are done? Cool, cool, cool. So now I want you guys to list me the complications you guys can think of that you guys can remember when it comes to leukemia, and just cancer, potentially just cancer in general. Like, what do you guys think about? What do you guys remember? Brittle bones, you can definitely have that. Sure. So brittle bones. Let's have brittle bones into pathological fall or pathological fracture. Neutropenia. Okay. Bleeding. Neutropenia kind of goes with like infection. So let's go infection, sepsis, hemorrhaging. Anything else you guys can remember? So right now we got brittle bones, fracture. We have bleeding. We have infection. Any like oncological things you guys remember? Tumor lysis syndrome? Yeah. So in general, for sure, like the use of your radiation or chemo breaking things down too much. Tumor lysis syndrome. Stomatitis, sure. Stomatitis is going to occur with a lot of the chemo medication because the chemo is going to help break down any rapidly dividing cell, which a lot of the time your mouth has a lot of rapidly dividing cells, so that's where you get the mouth ulcers from. Yeah, stomatitis. Usually it's called mucositis, mucositis, but it's kind of the same thing. Spelled it wrong. What about DIC? DIC is like a general complication of cancer. Okay. Swollen lymph nodes. Sure. We'll call that, we'll put that under finding. We'll put that under finding under here. Yes. And keep in mind, these are swollen lymph nodes and not tumorous lymph nodes. So even like, people have infections, they can have swollen lymph nodes with filled up with like lymph fluid. So not to be confused with tumorous lymph nodes, which um they're going to be enlarged because they're tumors. These are just swollen. So don't try not to confuse those because lymphoma, the entire definition of a lymphoma is that it's a tumor in the lymph nodes. So don't confuse those two. Um, yeah, pretty much. I'll put kind of like a general and then maybe more leukemia. Yeah, I guess that one's more general actually. Leukemia here. These are just kind of general. Oops. I guess this one's technically actually no, these are technically more leukemia specific because of the pancytopenia. You do have pancytopenia with a lot of cancer people, but that's because of their meds and not because of the cancer itself. If there's anything I would add to the general, uh, you can remember that there's the spinal, what's it called? Mm, the tumor syndrome, like the one on the back. Forgot the name of it. What's the name of that? Not tumor lysis. What's the other one? I'm gonna look it up. And then you also have it's like superior vena cava syndrome, but those are just general. Don't worry about the general ones as much. Focus more on the leukemia ones. Um, yeah, I don't remember the name of it, but it's bothering me, so I'm gonna look it up. Spinal cord compression, that's what it was. Superior vena cava syndrome. Don't worry too much about these. I'm just being a nerd. All right. So we talked about these. I'm gonna add one more for leukemia. We're gonna talk about hypercalcemia. So you have like the breakdown of a lot of time the breakdown of the bone leading to the calcium from the bone kind of chilling in the blood and causing hypercalcemia. Do you guys know what are some signs and symptoms of hypercalcemia that you can experience? Some of the main ones.
Muscle rigidity?
Yes, so muscle rigidity or weakness.
Yeah.
Tetany, that's kind of like the um well the tetany, I think tetany is more hypocalcemia. That would be like it would be like your Vostok sign and the whatever thing. Tetany is more like hypocalcemia. But you do have that. Anything else you guys can remember? I'm probably looking for one more big thing. not say I would say not so much. It can, but one of the big things it shares this with potassium. I'll give that hint. I mean, you can have nausea, vomiting, and abdominal pain. What else? What else is important about potassium that you always think about with potassium? Heart, yeah, like heart dysrhythmias, yeah. So something that you'll come to just kind of group together is like a lot of like your electrolytes, so your potassium, your magnesium, your calcium, your phosphate. All of these being out of whack can affect the heart. You can get dysrhythmias from all of these being out of whack. So that I just usually group a lot of these electrolytes with like heart arrhythmias. But I would say these are probably like the main two things. You can have altered level of consciousness. Um, but these are probably like the major things right here. And then I'll just mention that treatment is like flushing with high amounts of IV fluids. You're flushing it out, kind of like when someone gets rhabdo, they flush it out a lot of the time, and then try to manage the potassium. Um, yeah, just kind of. There's technically one more, bisphosphonates. Those are medications used to get some of that some of that calcium back into the bones. So away from the blood. But that's just one of the possible complications is hypercalcemia. Although it is a bit more common with the lymphomas from what I recall. And everything else we kind of talked about, it makes sense. If you have brittle bones, you have fractures. If you have pancytopenia, you'll have these two right here. This one's more specific, and again, these are general cancer complications that you don't need to memorize. It's just kind of there for review. Management. Do you guys remember there's a few medications that can go here, or like a few things that you can use for management. I believe that's true, yes. The prednisone. Methotrexate, yeah. Methotrexate's the one that they emphasize a bit more on the notes. So methotrexate, and then there's a few others that I don't expect for you guys to be like particularly tested on too hard. Um, yeah, like that. Like I don't, yeah, don't have to worry about it too much. For Tuxin, they also mention, I believe. Yes. Yeah. I'm only gonna write down the ones that are on the PowerPoint and that they for sure go over just so that and they're like you're not wrong, Alexis, but it's just that if you're not te if I know for sure you're not tested on it, then no point in like memorizing it just to clear your head out of things that don't need to be there for now. But yes, anything else you guys can think about? Or maybe I'll ask you this. What do you guys think about? So this person right here, um, they have a weakened immune system. Oh, nice. Oh, well, not nice. I hope they're okay. Yeah, I meant like you memorized the meds. Uh, what do you guys think about vaccinations for people with leukemia? Yes, no. Okay, so no live vaccines. Are we okay with it otherwise? Yeah, otherwise it's fine. Yeah. So vaccinations are important because they have a weakened immune system. So preventing them from getting sick is really important. But the live vaccinations, those are the ones that are essentially just like a weak versions of the virus or bacteria, whatever. I think it's virus usually. They will potentially get them actually sick because their immune system is that weak. So these include MMR, smallpox, varicella, kind of what I have here. And then lastly, what do you guys think about these patients being given antibiotics, antivirals, or antifungals? Yes, no, maybe. Yes. So, so yes. Just keep in mind, of course, your antibiotics, your antivirals, they can also, when someone is on these, they can also increase their chance of like opportunistic infections and stuff because you're immunosuppressing them potentially further. But it's just kind of like a risk versus reward. So you should give these, but just kind of keep that in mind that you have to watch out for like the super infections or like the opportunistic infections. But it's just like the reward is better than the risk, so you still give them. And then here's what the Rituxan, this is how they explained it. Let me see if that's monoclonal. Yeah, it's a monoclonal antibody. Yeah, yeah, yeah. Rituxan helps with certain autoimmunes and also like certain cancers, like the leukemia and the lymphomas can also help with that. Yes, so it helps to target proteins on the surface of the cancers, making it a bit easier for your immune system to help. But let's go over the methotrexate because there's kind of so what do you guys remember? I'm sure you guys went over it in class. What do you guys remember about methotrexate? I have like three main like points to keep in mind with it. Sure, sure, sure. Okay. I'll make it a little bit easier. How does it affect I guess it's kind of ironic, 'cause, like how does it affect the immune system? Not like pathway, just like yeah, there you go. That's what I meant. Yeah, perfect. Yeah, so it does cause immunosuppression. Again, it's kind of like the same idea. These people are already like immunosuppressed. This is gonna make it's gonna make that part worse, but the reward is they no longer have cancer and die, or they get treated for the cancer so they don't die that way. So it's again risk versus reward kind of thing. The reward is higher here, even though you're increasing the immunosuppression, making them potentially like um, have to be like under full neutropenic precautions and whatnot. It's worth it for what it does. Is there anything? I'll make things easier. Is there anything that you should take alongside the methotrexate? Any supplement that you should take while on metho? Yeah, should. Yes, folic acid. So this should be taken with folic acid because the methotrexate kind of inhibits it. So you take the folic acid so that you're not deficient on it. And then something that Mr. Robbins mentioned in our class, I'm gonna be honest, I don't think it came up, but I think it's good to know just in case, is this can cause the inflammation of an organ. Did he talk to you guys about this? Like the tinnitus of some kind? One of your major organs, inflammation on one of your major organs. I don't know if he talked about it. Not that one. Maybe it does too, but yeah, I don't know if he even brought it up. It's pneumonitis, so inflammation of the lungs. Oh, he did. Yeah. So pneumonitis. So you have a risk of pneumonitis for some reason in particular. Inflammation of the lung tissue. And yeah, so some of the signs and symptoms include fever, shortness of breath, a dry cough. You can kind of just guess from the fact that it's like a lung inflammation that it would come with some of these, I think. The shortness of breath makes sense with lungs. Cough of some kind makes sense because it's a lung thing. And then fever because it's an itis. So I suppose like, kind of just keep in mind while you're on this med, they should have like their lungs assessed and things like that. And then the folic acid. So you should know this one. This one's your main focus, really. It's the methotrexate is your main focus. Everything else might be a little bit more like good information, but not like super hyper important. Like you're not going to get directly tested on this. This is just like, and this one's just like a good thing to keep in mind is that it's a risk versus reward. They should still be on it. And this is something to keep in mind, I think. Okay. Any questions on anything we talked so far? I will go through the specific leukemias, but it will not be hyper detailed because you don't really need to know them in hyper detail. Your main things to know are going to be your assessments. What do those assessments lead to? So what we talked here in the findings section and how to treat it. And then maybe like, why do we do this? Why do we do this? That's going to be your main real thing there. Any questions on anything so far? Okay. So again, this one's going to be pretty fast. Um, I don't know if you guys remember when we talked about the difference between lymphocytic and myelogenous. Like what's the difference between them? You don't need to know the difference between them, but the main thing you kind of have to know, it's good to know is just that the myelogenous ones are more severe. And this picture explains it, but again, it's a lot of information. You don't have to know it, but it's just here to kind of show you. See, you hear lymphoid and myeloid. So this is where the names come from. You can see here the lymphoid side only has white blood cells. The myeloid side has red blood cells, platelets, and some white blood cells in it. So the myelogenous ones affect more things at once, and it directly affects it. The lymphoid side affects only a few things, and everything else, um, in terms of like the pancytopenia part of it, is indirect, just because these cells take up so much space. And that's as far as you really have to know. You really don't need to know any detail on it. That's just kind of how it is. The myelogenous is more serious than the lymphocytic. And then that's like the bare bones explanation of it. Okay. Some special information here. I would say it's just this is most common in children. Let's say 1 through 9. Let's say high risk is younger than 1, older than 9. And that's everything else, like in terms of manifestations, we've already talked about it. It's already kind of implied there. Treatment, the way I remember it is you have ALL all, so all kids. Um, I just remember all kids get cancer because I just do, and then all kids, they get all treatment. So they have potential to get chemo, radiation, maybe stem cell transplant or something like that. Don't worry about specifics. You really don't need to know any specifics for these. Realistically, it's more about the symptoms and the management. Any specifics is just there for context. Your chronic lymphocytic is just most common in above 50, 50 plus. Acute myelogenous. Let's see. Most common in adults, 65 plus. This is severe because remember, this is acute. Acute's always going to be more severe than chronic. And it's also myelogenous, which we kind of go back to here. It directly affects all three types of cells, as opposed to the lymphoids, which only affect the white blood, like these parts of the white blood cells directly. Um, and the reason this side causes pancytopenia is if you recall, normal cells have contact inhibition. So when they're being overly surrounded by other cells, they know to stop replicating. But cancer cells don't have that distinction, so they'll keep replicating and overcrowd everything. And then these cells that aren't directly affected by the lymphoid stem cell, they'll see that there's overcrowding and they'll stop replicating as much. And so it indirectly causes pancytopenia that way. But the myeloid side will directly cause it, which is why it's more severe. But again, extra info, don't worry about it. Um, this person will need to be probably like long-term chemo management. Chronic myelogenous, most common in 50 plus in terms of age, years old, years old, years old. They have the Philadelphia because it's chronic, it's slow, it's a slow onset. That's honestly all you got to know. There's other like specifics information, but I don't recall it ever being tested on. So you have like 4 topics for this test. Just focus on the important stuff. Any questions on this? Oh, yeah, that's unfortunate. But yeah, it's aggressive. Yeah. Cancer is never fun to talk about. It's always sad. Okay. So We'll talk about lymphoma now. So the difference between leukemia versus lymphoma. Leukemia is cancer of the bone marrow. Lymphoma is a tumor specific. That is the key difference. It is a tumor. They're very similar, and actually your leukemia can become a lymphoma on top of what you have because remember that you have cancer cells uh, in these in the bone marrow and the lymphatic system, so it's easy for it to spread around. It's easy for those cells to migrate to lymph nodes and then become tumors there. So leukemia can create lymphomas, and then lymphomas can, where am I? Can break off like like parts of that lymphoma can break up, make its way, and then become leukemia. So it's kind of like they're pretty tied together. But the main difference is that this is a tumor. That's what the oma means tumor. So tumor in the lymph system. Oops. Um, yeah, so I've kind of written that here. That's like the main difference here. So between Hodgkin's and non-Hodgkin's lymphoma, I do have a way to remember some of the signs and symptoms. But for now, we can just talk about kind of some defining traits. Can you guys think of some defining traits for Hodgkin's lymphoma that is not found in non-Hodgkin's lymphoma? Yeah, so you have large, painless masses. Anything else? Yeah, the Reed-Sternberg cells. Yes. And then I would also include, um, yeah, something like that. Yeah, the Reed-Sternberg cells, essentially, it's the cells that can be found in Hodgkin's lymphoma, and it can also be found with the Epstein-Barr virus. So that's your like mono can have it. And a lot of the time, the Hodgkin's lymphoma can actually follow like an infection like that, like a viral infection. You can have Hodgkin's lymphoma following like a viral infection. It's more organized, yes. So it's more organized, yes. I have a picture for you. You do not have to know the staging of it, but this kind of gives you a general idea. So symptomatic includes fever, night sweats, and weight loss. So these are some of the symptoms that you'll find with Hodgkin's lymphoma. And again, you don't have to know the staging of it at all, but it's just kind of showing it's more organized. It's able to be staged more easily. Is back pain one? I honestly don't know the answer. I'll look it up. Maybe depending on the pressing on lymph nodes. It can, but it's not common. But it would be more like the lymph nodes pressing on the back, or if they have like spinal cord compression or something, which is more like a more advanced cancer complication. Usually you have like metastasis at that point, and you have like a tumor growing in your spine, and that's causing pain, pinching nerves. Potentially, you're having issues feeling your legs. Yeah, so if you have spinal involvement, so like the C spreads to the bone and stuff, it can happen. But it's not a common, it's not a very common, it's not a common, like everyone with Hodgkin's has it kind of trait. But yeah, like Khaled said, it's more organized. So to the point that it has staging. So it'll usually start above this waistline, kind of this line here, usually at the neck area. starting at the neck. And then stage two is essentially when you have another one, another group of another tumor somewhere with still within like this above like halfway point of your torso. Stage three, that's when you start having tumors both above this line and below this line. And then stage four is you just have you start having very large masses, um, and stuff like that. But again, you don't need to know the staging. Just really focus on the important stuff. So you're gonna like the Reed Sternberg cells, their large, painless masses, and some of the symptoms. Okay, I'm trying to see if there's anything else. We'll talk about the management. See how I can. All right, how does this let me? Boom. Nope, it's not the button. Just do like that. So we'll do management here. I would just say the general idea is external radiation stages one and two, but even then, I don't think you have to hard memorize any of this here. It kind of goes with the typical pattern of early stages. You could try just radiation, maybe surgery if you can get there. Late stages, you need chemotherapy because it's more systemic now, and we're hopefully trying to prevent metastasis and stuff. While at the earlier stages, you can see here it's more localized. So you're able to handle it with radiation, external radiation more easily versus this where it's more spread out and you'll need chemotherapy. And now we have non-Hodgkin's lymphoma. So the way I remember this is just based off the word none. So yeah, no for everything. So for example, you have red itchy patches, which I say no, you have no good skin. That's how I remember that. It typically spreads throughout lymphatic system in a less organized fashion compared to Hodgkin's. So I remember that by thinking of there's no order to it. There's no Reed-Sternberg cells. Um, there is hypercalcemia. So like I mentioned, hypercalcemia can occur in leukemia, but it's actually more common in the lymphomas. And the explanation here, I'll just copy paste this actually, it's easier. The explanation for that is you have that cancer cell infiltrating the bones, leading to bone breakdown. So you have calcium being released from your bones into your blood. And I remember that by saying you're not allowed to have bones, no bones allowed. So everything here to remember it is with the word no, because it's non-Hodgkin's. So compared to Hodgkin's, you have no good skin. You have those patches. You have less order, no Reed-Sternberg cells, and your bones are not allowed to stay as bone. No bones allowed. So hypercalcemia. Um, and and I would say like I mentioned, tumors can be painful. Not necessarily always, but they can be painful especially more advanced. And then let's just say findings. Put this all together and then have management. You have chemo again, same idea. Chemo and internal radiation if caught late or late stage. And there's some other stuff that you don't gotta worry about too much about it. Like I said, I do think this topic is less important for that midterm. It will just be like the very key things. That's why I also mentioned don't hard focus on a lot of the hyperspecifics because it simply will not be tested on. So in this case, the specifics, I would just say the differentiation between the non-Hodgkin's and Hodgkin's, probably these signs and symptoms, the Reed-Sternberg cells, um, the symptomatic signs and symptoms. Remember that lymphomas are tumors. Leukemia can have swollen lymph nodes, but that's not swelling due to tumor. It's just swelling because your lymph nodes are full of fluid. Um, Again, you don't have to memorize the staging. And then the management is pretty typical with all like a lot of the cancer things we go over. It's just radiation, localized radiation, if caught early, external localized, if later stage chemo, because it's systemic. Okay. Any questions so far? We are on the last topic, and there's only like a few like hyper important stuff on this one too, like hard no. Okay. So multiple myeloma is a cancer of the plasma. Don't worry. If that doesn't make sense to you, don't worry about it. You don't need to know further than that. Um, what is like one of the biggest traits that they probably, or some of the biggest things they talked about with this one? We'll talk about it after as well. Okay, sure, bone pain. Anything else you guys can think of? So you have a buildup of plasma cells overcrowding the bone marrow. So if you guys remember when we were talking about myelogenous again, um, the lymph kind of going back to that picture when we have overcrowding. What happens when we have overcrowding? Anemia is definitely on the right track. Anemia is part of this word. Infection, again, part of the big overarching word. Pancytopenia, yeah. So again, that's the anemia, thrombocytopenia, and leukopenia. And this is again due to overcrowding in the bone marrow because same idea as the kind of like the leukemia ones. You have too many, even though it's not directly any of these specific cell RBCs, platelets, uh, uh, and white blood cells. It's indirectly causing it just because of the overcrowding. Mary mentions CKD, so yeah, so like renal dysfunction. That's probably like the key, one of the key things here. It's the key thing other than like one more thing that you might like the presence of something. So we'll talk more about this. There's like something in the blood that can be found with the multiple myeloma. The M protein, yeah. So that's the M protein, which is basically just your cancer plasma cells produce proteins and it gets in the blood. And it's called the M protein. That's the definitive trait. I'm sure if you saw M protein, you would think multiple myeloma. And we'll go over more things about renal dysfunction. Hypercalcemia, yes. So kind of like the other one, we have bone pain, and then we have hypercalcemia as well. So for pretty much the same reason, we just have um, as above, is we just have um, cell infiltration leading to breakdown of bones, and again, if we go back up even further, because we have hyperkalemia in all three of them, we can remember the complications of that. Just arrhythmias, alter level of consciousness. And then one more thing that I don't think they go over, just I saw this come up on UWorld question. The Benz-Jones protein in the urine. That's about all. That's pretty much it. But it's just extra. I don't think this ever gets tested on, so it's just extra info. But let's talk about renal dysfunction. So what are things that we're thinking about when we're thinking about renal? What labs are we looking at? Yeah, F&E, sure. Yes, so we're gonna have elevated BUN and creatinine. Yes, so impaired or probably like impaired drug metabolism leading to increased risk of toxicity. Yes. Decreased urine output. Yep. We said F and E, so go into more detail. What electrolytes are affected? Yep. So how is potassium affected? Hyper, yes. Yes, we can also have low H and H because due to kidneys not being able to produce erythropoietin. All right, what happens to the sodium? Yes, decrease. It's dilutional hyponatremia. So if you guys recall, you have decreased urine output, and alongside the decreased urine output, if you recall, like when you have hemorrhagic sh shock or like you have a hypovolemic shock, your kidneys compensate by um, holding onto your fluids. The same thing with like the acid, they hold onto your fluids. In the scenario of having like hypovolemic shock, it's there to stabilize your blood pressure. But in the case of you not having blood pressure issues, but your kidneys still kind of not working to the point of making urine, now you have fluid volume overload for the same reason. Like you're not able to properly make urine, so the fluids stay in your body, and that leads to fluid volume overload. And then that fluid volume overload leads to delusional hyponatremia because your sodium's affected by the fluid in your blood. And if you have too much fluid, then it dilutes this one. Pretty much. Let me see if anyone else says something. We said that. We said that. Um, and then the only one I'll mention otherwise is your magnesium is also hyper magnesemia. Magnesemia. Mm, yep. And then if you didn't know, hypermagnesemia, I'm sure it does a few other things, but for the most part, I just think of hypermagnesemia like we talked before, like arrhythmias. Same thing with hyperkalemia, just think about arrhythmias, if I could spell it right. That's still wrong. Okay, there we go. And delusional hyponatremia, think about seizures. But that's that for the most part. I think that's pretty much everything. We have elevated BUN. Maybe you can put decreased GFR. Kind of goes with that. You guys mentioned the metabolism of drugs. You mentioned the H and H. You mentioned the F and E. So for sure, keep these in mind here. Did they test? I don't think they directly taught you guys this, just because I don't think they did, or maybe they did. I don't remember. you guys have a kidney lecture later. Um, yeah, definitely keep in mind this. And then this is a good thing to keep in mind as well. Oh, and obviously this. All right. We talked about pancytopenia. So last thing to really talk about is just the interventions. Do you guys recall? Oh, actually, one more thing. Actually, one more potential thing that could come up here. When you do make urine, what could be found in the urine other than the Benz-Jones protein? Well, I guess I kind of said it. I guess I kind of already said the answer, but we'll make the connection anyway. You guys remember when you have what's one of the first signs of renal impairment in like a diabetic? It's the protein in the urine, yeah. So protein in urine, and we mentioned that that's the Benz-Jones, plus probably some albumin. Okay. Yeah, so what interventions do you guys recall when it comes to multiple myeloma? How do we help our kidneys out? Yeah, let's flush. Help them restart, get some flush. So IV fluids to flush out um, proteins from blood and help kidney function. So your kidneys like water, kidneys like perfusion. So that's kind of how you're gonna go about it. Maybe one more thing is we can add decrease urine output. So you have decreased urine output, and because you have decreased urine output, when you do pee, it's going to be very concentrated, but you're also not getting rid of like the uric acid. So you have also hyperuricemia. So you have high uric acid in the blood. So this helps to also flush some of that out. Plus, you also have hypercalcemia from the cancer, so helping function and flush the calcium as well. What medication helps with, yeah, bisphosphonates helps with hypercalcemia. So bisphosphonate, the main one's Someta that he says hypercalcemia. What's a good medication for hyperuricemia? For uric acid buildup, what's a good medication for that? Starts with an A. And we mentioned this is cancer, so yes, we're gonna have chemotherapy.
Allopurinol.
Allopurinol, yeah. So allopurinol for the hyperuricemia. Um, it's gonna have some pain, so think about pain medication. And because we have kidney issues, is there anything that's contraindicated? Yeah. I don't know if he's mentioned this because he loves mentioning it. Is there anything that he said is can be helpful to help your kidneys out if you still need to do
Mucomist.
yeah, mucomist. Yeah, he says that a lot. He loves that. He loves that one. Mucomist, yeah. Which is also randomly the antidote to Tylenol. So it's given for like a Tylenol overdose. So it just randomly has a lot of uses. Sorry, let me fix this. Contrast isn't contraindicated. Mucomist can be given. There we go. That's literally it. That's pretty much it for the most part. Let's kind of go back up. The M protein, the renal dysfunction is going to be some of your main things. Fluid volume overload. Think about your FNEs. You still have pancytopenia. So all of these are going to have pancytopenia. Um, with your multiple myeloma, you're going to need IV fluids to flush things out. the allopurinol for the uric acid. Just remember the contrast thing. But that's everything on this topic. Any questions on anything here? And then, like I mentioned, we'll do liver and pancreas um, next Tuesday. But if I don't finish or you're not able to make it, I linked two previous recordings of it already. Let me know if you didn't receive it, if you weren't here early, and I'll give that to you. So that would be the recordings from last year that I did for last rotation. So here's the hematology outline. And then if you need it, I will post the recordings. Where is that thing? Yeah, I'll post both. Give me a second. Stop the recording. Actually, I'll keep it so that if someone is watching the recording, they can check the chat logs for it again. Da, 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 da. There we go. Here's liver, and here is pancreas. And keep in mind that the session I will hold on Tuesday will not be as long as these two combined, just because since then I've refined it a bit and it's more just the nitty gritty, and I really took away a lot of the fluff. So a lot less patho in it, which because you don't really need it, and just pure like assessment, interventions, complications, everything you need for you'll need for the test, and less of the extra stuff. But yeah, that's pretty much it.